Hello world. My name is Katerina Fechuk, and I'm a pediatric ophthalmologist from Kyiv, Ukraine. I'm very delighted and honored to co-moderate today our Global Grand Rounds number 5 with Dr. Mohamed Yanis from Lebanon. And we are having a great
Don't leave us hanging. We're having a great what?
Yes, we're having two great cases, strabismus and non-strabismus one. And I'm just trying to share the screen. And here it goes. Just a moment. Okay. Mohamed, can you help me?
So while you're sharing your screen, I can tell you all that we are, I'm getting messages that we are live around the world, in the UK, in Lebanon, in France, Germany, Chile, Brazil, Saudi Arabia, Israel, Nigeria. I'm looking at the list. In Hong Kong, in Singapore, in Australia. While you're sharing your page, your desktop, I'll keep telling everybody where we are. We are in China, it looks like, which is amazing to me. The United States of America, Canada, Greece. We are in India. We're in Pakistan. This is worldwide, and we are showing worldwide.
So we have actually, shall we go over?
Yes.
Do you want to share your screen, or we'll just talk about it?
Just 1 second. Oh my God, I can't open the screen. All right. So we are having two cases. And dear audience, we are delighted to have you here. And we are happy to see you on Facebook and YouTube channel. Actually, we've been told that Facebook is not working right now, but welcome to YouTube. And please share your questions on the comment screen, since all the questions, as many as possible of them, will be answered live. And the ones that won't be answered will be later shared on the PDF file on the official WSPOS site. And please traditionally visit manti.com. We are having Mentimeter questions. There are 10 of them. And please share the first 4 ones. Again, manti.com. And I'll share. Yes.
Katerina, they need the code.
Yes.
Yep. Or the number. If I have the number myself.
Can you share it?
55740-3225.
And Mohamed, if you have the introductory slides, you can show them too.
I don't actually. It is not in my background in here, just unfortunately. I thought. Because we just shared it now.
I don't know why it's not working.
All right. Well, if you get a chance, email it to me. I'll make sure it goes up and we can go forward.
Actually, we have 2 presenters, Dr. Raul Bola from Orange County and Dr. Snehal Ganetra from LV Prasad. And actually, we have for the non-strabismic discussant, we have Dr. Ramesh Kanaya from LV Prasad, and he is the executive from the executive bureau of WSPOS, and he's a chief pediatric ophthalmology in LV Prasad. And we have also Dr. Ken Nischel, the director of pediatric ophthalmology in University of Pittsburgh, and he is also the co-founder and the executive bureau of the WSPOS. And for the strabismic discussant, we have Dr. David Granite. I don't think we need to just introduce him. He's a world-known authority in strabismus, and also he's a chief pediatric ophthalmology in the UCSD, Shiley Institute in the Department of Ophthalmology, and vice chair. And also he's a co-founder of WSPOS, and also one of the executive bureau of WSPOS. And we have also Dr. Asmina Matasfi from Greece, Saloniki, and she's the associate professor of pediatric ophthalmology and strabismus, and she will share with us also her knowledge in this grand round. And my co-moderator is Katrina Fitcher, and she's a pediatric ophthalmologist, associate professor from the Department of Ophthalmology and Eye Microsurgery in Kiev, Ukraine. And also we have the presenters, Dr. Raul Bola from Orange County, as I mentioned, and he's the chair of Ophthalmology Children's Hospital of Orange County, California, and the associate professor of Ophthalmology, University of California, Irvine, and member the committee, program committee of APOS, and past senior editor of the American Academy of Ophthalmology Online and Education Network. And he's the deputy chief editor in Ophthalmology Business Minute. And also we have, as I mentioned, Dr. Snehal Ganatra, currently working as a consultant ophthalmologist in LV Prasad Institute, India, and had a fellowship in pediatric ophthalmology and strabismus from Arvind Eye Hospital, Madurai. And she has interest in pediatric cataract and complex strabismus, and she loves traveling, singing, and baking. Also, can we just leave it to our co-moderator to just introduce, or yeah.
And my savior, Dr. Mohammed Yanis, who's the consultant ophthalmic surgeon, MD from Lebanon, a pediatric ophthalmology and adult strabismus, co-chair at Eye Department, Rafik Hariri University Hospital, Eye Deputy, American University of Beirut Medical Center, past president, Lebanese Ophthalmological Society, president-elect, American College of Surgeons, Lebanon chapter, and board member, Scientific Bureau, World Society of Pediatric and Strabismus. Thank you, Mohammed.
Thank you, Katia. So we start with the strabismic case by Dr. Raul Bola from Orange County, California.
Raul, before you begin, let me just make one other quick announcement. Ramesh Kekanoya from LV Prasad, a dear friend, has contracted COVID. He's doing well, but he's likely not going to be able to be with us. If he feels a little bit better, he might jump in, but it doesn't look like it today. Our prayers are with him. This is real life and things happen. Fortunately, thanks to God that he has been vaccinated, so we hope that it'll be mild. And Ken Nishal, one of our other discussants, is planning to be here, but he is literally in the operating room right now. This is a live discussion and it happens in real life. And Ken is with an emergency patient, and patients always come first all around the world. So hopefully he'll be able to join us for the second discussion. And we look forward to him taking first good care of his patient and then secondly joining us. Well, sorry for that, but I wanted to make sure everyone knew what was going on.
Thank you so much, David, and thank you so much to this illustrious panel for inviting me to present this interesting case. And thank you to the WSPOS Bureau at the outset. I'd just like to mention that my thoughts and prayers are with everyone around the world, who's suffering right now, whose families, friends, especially in India, where there's been a pretty significant upsurge. So our thoughts and prayers are with all of our friends. So I'll be presenting a very interesting case which actually defied the Occam's razor, which basically is a scientific rule which guides us to choose one explanation when there are multiple findings. So this case is a very interesting 5-year-old, very pleasant male who was sent to me to evaluate abnormal eye movements with normal head tilt. The patient recently moved to Orange County, California from Mexico. So we did not have any medical records of this patient from prior. Although mom said that she has noted this misaligned eyes since infancy, and he also had droopiness of both eyelids at birth, which actually improved over time. On exam, our patient had a pretty good visual acuity of 20/30 in the right eye and 20/25 in the left eye at distance, and near he was J1 with both eyes. On external exam, there was some frontal bossing with pupillary exam showing a 1+ APD on the right side. The anterior segment exam was unremarkable. Intraocular pressure was perfectly normal. He was in the primary position fixating with his left eye with a significant anomalous head position, about 25° of right face turn, 20° of right head tilt, and about 20° of chin down position. The posterior segment exam, as you can see, showed some temporal pallor of both nerves, but a significant encyclotorsion of both the fundi. The left slightly greater than right. Here you can see I've drawn the arrows of what the normal would look like and where the macula was. So about 20 to 25° here, about 20° here. The ocular motility exam was significant for a large angle exotropia in primary position with severe limitation to elevation in the right eye with moderate limitation to elevation of the left eye. There was severe limitation to adduction of both eyes, moderate limitation to abduction of the right eye. There was upshoot of the right eye on depression. And there was also lid retraction of the right eye with depression and levoversion. There was also very interesting synergistic divergence of both eyes when he tried to adduct the eye. And of course, he did not have any stereopsis. So I'll open the discussion for the panel while I play the video of this patient. So here's the video showing elevation, limitation of elevation in the right eye, limitation in the left eye, upshoot of the right eye in depression. There is synergistic divergence in adduction, limitation to abduction of the right eye, lid retraction on levoversion. So I would like to hear the thoughts of the panel at this point. We can go with the mentee question as well to what the audience feel is the diagnosis of this patient.
So, I'll jump in.
Ken, what do you think?
So, I think that I just want to go back a little bit. He had, his head is large, right, Raul?
Yes, David. Yeah, he's got some frontal bossing there.
Yeah. It's interesting, in a kid, right? If you have elevated intracranial pressure, your head gets bigger if that happens when you're young enough, whereas an adult it doesn't. And his retina looked okay from the view I could get here on my screen. I didn't see any particular swelling of the optic nerve, but there is pallor. So, if you have elevated intracranial pressure in an adult, if it's long-standing, eventually you can get pallor, but you would expect to see an elevated optic nerve. But in a kid, it could be pallor from the head gets bigger. So you start thinking about that. What's interesting is that his eyes are in an abducted position. The movement of the eyes looked like something, at first I was thinking that we had maybe congenital fibrosis with a head position, but that's usually a chin up position. And now you're seeing when he looks down with the left eye, the right eye goes up. So you start thinking about something going on with the third nerve of some sort, which congenital fibrosis is an oculomotor nerve problem, right? It's the nerve doesn't stimulate the muscles to grow correctly. He has an APD, of which if the pupils are going to get involved, that would make it the more rare type 2 congenital fibrosis, which Muhammad has been reported in the Middle East, but not so much here in the United States. But it's only in one eye, and he has pallor in that eye. So I'm a lumper. I like to put things together when I can, and I'm having trouble putting this all together. I guess it could be a third with a change in the innervation, and maybe related to something going on in his brain. And now he's got synergistic divergence. He's got elevation on down gaze in the right eye, and a pupil involvement. Maybe that's all third and not related to amblyopia or the optic nerve damage. I'm not sure yet. I feel like I need more information and I need to look more. Asmina, do you have any thoughts?
Yes, I just unmuted. I'm intrigued because he has external ophthalmoplegia. I think it's severe enough limitation of his eye movements to call it an ophthalmoplegia. And he also has involvement of his lids. Right now, he's not using a chin up, but he is using his brows, his forehead. And it is reported that he had ptosis that got better with time. And then he's also got pupil involvement. So he has internal ophthalmoplegia too. And he's got his optic nerves involved in that he has no edema, but a certain amount of atrophy. So I would be inclined to investigate more, as you said, get a full workup clinically. I would ask the pediatricians to have a thorough look at him, and possibly investigate with some imaging of the brain to see if this bossing of the forehead, this bilateral optic nerve atrophy has some pathology in the brain too.
Well, just a quick question. Do we have a picture of his parents?
Actually, we do not, but I only met the mom, and she appeared perfectly normal. There was no other, craniofacial or anything, no strabismus that I saw. So she appeared perfectly normal. Yes.
Because the congenital fibrosis, first, I don't usually expect such normal elevation in the right eye, even though it happens at the wrong time. And usually, the types 1 and 3 are dominant. So you would have expected to see something in a family. I know you're not describing the dad, but type 2 can be recessive, and it does have pupil involvement. So it doesn't quite fit, and it doesn't seem to be progressive. So, and the retina looked okay. We may end up getting some genetic testing. I'm wondering, because if it's progressive and he has pigmentary changes in the retina, we start worrying about other issues like Kern-Sayer, but it doesn't seem to be putting that together. I don't know yet. I don't know yet. I'm hoping you'll help us.
So excellent discussion so far. I was equally intrigued because, I'm like David said, I'm a lumper as well. I was trying to put everything together. And in this particular case, I was not able to do that because there are so many different things going on right now. So as we always suggest, I definitely wanted to get a neuroimaging done right away just to make sure that we are not dealing with something that's actually progressive, even though from the history, it seemed like that this has been there since birth and is non-progressive. But so we proceeded with so at this point, even before the imaging, let me kind of go over what I was thinking about from the differential point of view. So definitely it's some sort of a congenital cranial disinnervation syndrome, like David and Meena pointed out, with bilateral partial external ophthalmoplegia. I'm calling it partial because still the eyes were moving. So it's some sort of external ophthalmoplegia. And so I wanted to kind of put this under the umbrella of the CCDN syndromes, but there are still certain things which did not fit there or were associated with a cranial disinnervation syndrome. For instance, there was an abduction deficit of the right eye, kind of like a partial sixth nerve, which did not fit with the picture here. So the first thought, of course, was the bilateral congenital third nerve palsy with aberrant regeneration of the right eye and possible pupillary involvement of the right eye as well, which is could be some sort of internal ophthalmoplegia like Meena was mentioning. The CFUM definitely thought about it, asked extensive history about the family members, could not elicit anything in particular. CFUM typically, in my experience at least, the ones that I've seen have significant ptosis, although it can vary between the variants. And I did not elicit, even though he had a little bit of brow lift, I did not elicit any significant ptosis. For the, I actually thought about Duane syndrome as well, because there was a adduction limitation in both eye with what appeared to be an upshoot in the right eye, but definitely the lid changes were not there, which were suggestive of Duane's. So I kind of negated that diagnosis, even though that's part of the congenital cranial degeneration syndrome. And then in the back of my mind, I had some congenital extraocular muscle structural abnormality, which could cause this kind of a picture as well. So as David and
Raul,
yes.
I'm just kidding. I mean, you know, I found that Duane syndrome was a lot easier when I was a resident because there were 3 types and that was it, right? I mean, it was very straightforward. But I think anybody who does a lot of strabismus recognizes that Duane syndrome has such this large spectrum of what it exactly looks like. So I agree with you in including that. And I think that that's an interesting idea. And I haven't seen Duane syndrome do, you know, where you go to down gaze and the other eye goes up. So I'm with you on that. I think this is an interesting pattern of deviation that it doesn't fit what we normally see, but that's what happens in real life. You occasionally get these patients who don't fit what you normally see. What I've found in my travels around the world is that as I leave the United States, I see patterns that I don't see here that are seen elsewhere often. So I'm curious if, like, for people from other parts of the world than I come from, if this pattern looks. Mohammed, have you seen this pattern before?
Yeah, not like this, but sort of. Yes, you're right. You're absolutely right. So Duane Duane syndrome is in the picture now in this patient. I can think of it myself also. So because of the upshoot and also because of the restriction, and you can see it that with limitation in A deduction and abduction.
So I don't want to keep much suspense there. I want to go ahead and show the MRI findings because I think that was very interesting. So for me, the diagnosis at this point, as all of you alluded, was bilateral third nerve palsy, possibly pupillary sparing. Again, I was not 100% sure about that with that APD in the right eye, with the aberrant regeneration of the right eye, with associated right sixth nerve paresis, and with bilateral optic neuropathy. So at this point, I wanted to get an MRI and a neurology evaluation. So we send the patient to neurology and schedule the neuroimaging, MRI brain and orbits, and possibly scheduled for a future strabismus surgery, depending on the findings. And lo and behold, we get the MRI.
All right.
And so the MRI showed pretty severe ventriculomegaly with the absent septum pellucidum defect and severe thinning of the corpus callosum. So at this point, what does the panel think? What should we do at this point? It's pretty evident there's severe ventriculomegaly. So
we should refer him to neurosurgery and pediatric neurology.
Excellent. So that's what I did. And actually, I placed an urgent referral.
I'm sorry, Raul, did he have nystagmus?
He did not.
Good question.
It's so interesting.
Right. And again, still, even despite of the MRI findings, I was not able to fit this picture together, so maybe there are 2 different diagnoses going along here. but I did place an urgent neurosurgery referral, and they ended up doing a VP shunt right away. And 2 months later, the patient was recovered and was sent back to me for further management.
So what a great, I mean, that alone is such a great and important thing that you did for this child and this family, right?
Absolutely.
I mean, here you're the ophthalmologist, and as the ophthalmologist, you know, you made a diagnosis that could affect his life forever in terms of what he's able to, his function, et cetera. Bravo.
Yeah, absolutely.
Very intriguing, very interesting indeed. So at this point, David, I would actually like to ask you about what would you do from the strabismus standpoint. I can actually show the slide, you know, where I did the force duction test, and actually let me do that, and then we can go over what we would like to do in terms of the strabismus surgery. So interestingly, in the surgery, I did the force duction test first. In the right, I showed mild restriction in adduction, mild restriction to adduction, but the elevation, depression, and abduction was completely free. The left eye, it looked like a Brown syndrome picture. You know, there was definite severe restriction to elevation in adduction of the left eye, although there was limitation to adduction as well, which we don't see in Browns, you know, but there was severe limitation to elevation in adduction. The abduction, if you can see here, the elevation in abduction was completely free, but there was severe limitation to elevation in adduction. And the elevation and the abduction was completely free as well. And mild, I would say about -1.5 limitation to adduction of this left eye. So this was so interesting, and I don't want to keep any mystery here, but when I did I opened the conjunctiva, I did a conjunctival peritomy, and I actually disinserted the lateral rectus muscle. I saw this big band, you know, running. It was like an accessory band, which was coming from the posterior infratemporal quadrant and was going below the lateral rectus muscle and was attached all the way above here. So, which is possibly what was creating this pseudo Brown syndrome in that left eye on FTD at least. So, what are your thoughts, David? Have you seen this, Mohammed, David, Meena?
Yeah. So I'll jump. I mean, I'll jump in if it's okay. I have not seen it, but I have heard about it and read about it.
I've read about it myself, but I've never seen it.
Yep. There's if we think about evolution and humans versus animals, there's a structure that retracts the globe in animals, the retractor oculi, and it's been reported in humans as an atavistic structure that's a remnant. And God, it's years ago now that Greg Leader wrote a great article in Survey of Ophthalmology about these orbital structures. And but in animals, it pulls the eye back and allows the third eyelid to cover it. It also, if you hang your head down, it's supposed to help when you pull the eye back. So that's been reported. I've never seen it, and maybe because I don't look for it, maybe it's been there, and I don't MRI everybody, but I haven't seen it.
You know
Did
what?
you do MRI for the? Sorry,
Rahul, there is a question from the audience actually about how were the muscles on the MRI?
Excellent question. So I'll actually show the MRI later, because in retrospect, I went back to take a look, because when I looked at the extraocular muscles, they appeared perfectly normal. So I'm going to actually show that later in the presentation, how they look. But, you know, I was actually expecting some changes in the muscle, thinking about the CFEOM spectrum. The muscles look perfectly normal. And as David said, you know, we sometimes do see some accessory muscles like bifid insertions of inferior obliques. I have seen some accessory muscular remnants before, but I've never seen like a band, so I did send this band for histopathological exam as well. And it was fibrotic, you know, it was just fibrotic tissue. It was not any muscular tissue. So So on that basis, I planned my surgery around this, and I'm going to actually play the video what I did. And so I
Raul,
did
before you go on,
Can we get MRI? MRI.
That was the left.
It's the muscle.
Yeah, that was the left eye, correct?
Yes, yes.
But the right eye also had abnormal movements. So you're putting this together as the right eye had a third and aberrant regeneration, and the left eye has this band, or because of the band, the two eyes aren't working. I mean, when the left eye when he looks in down gaze with the left eye, the right eye goes up. I'm not sure how that band in the left orbit explains that.
Does not explain that at all. I completely agree with you, David. So I was actually kind of still intrigued, and I didn't want to do multiple surgeries at the same time, so I thought at this point, what is my goal of surgery? In the OR, I'm sitting and I'm thinking about what is my goal of surgery. So my goal of surgery essentially is to correct his head position, right? At this point, the medical issue has been taken care of. And I want to now correct his head position so that, he can at least hold his head straight ahead. So I started thinking about how can I achieve that? My thought process here was that if I can lower that left eye, which is the fixating eye, and I can kind of fix that eye in the primary gaze, maybe his head will be better positioned. So I decided that I'm not going to touch the right eye, even though I really wanted to do that, at least look at the band. If there's a similar band running there, I restricted my surgery to the left eye. So what I did was I actually disinserted the lateral rectus, and I'm going to play the video here. And this is the medial side. This is the lateral side. I hang back the muscle about 17 millimeters from the limbus. I excise the accessory band temporally. And then I did a medial rectus anchoring to the nasal periosteum. This is a procedure we described way back in 2006, where, I actually anchored the medial rectus with a non-absorbable suture on the periosteum just above the anterior lacrimal crest, and kind of moved that eye a little bit in the ESO position so that I can actually fixate that left eye in the primary position in the hopes that I'll be able to actually fixate that left eye. And once I excise the accessory band, it will actually stay there and not show this elevation deficit. So, we did that. And to Katya's question of the MRI, we actually looked at the MRI. I went back and looked at the MRI to see, if now I see anything unusual. And lo and behold, I do see this band right here in the left eye. You can see it closer. There's like this band which is coming from the lateral rectus, way posterior, and actually inserting to the globe posteriorly. And then, I couldn't get any interior extension of the band, but I'm assuming that that's the band that's actually going now interiorly and inserting below the lateral rectus muscle, and it's probably creating some sort of a leash effect here and some sort of restrictive effect anteriorly. So I'd like to hear the thoughts of Mohammed, David, Meena, Katya. What do you guys think?
Rahul, did you see a band? Did you see a band in the other eye?
I did not, and I actually looked at that. There was some prominence here, but I couldn't appreciate any band in the right eye.
Raul, audience actually is asking also about headache or other neurological symptoms.
So the child was kind of a little developmentally delayed, speech delayed as well. But he appeared pretty, apart from that developmental delay, he was pretty normal.
And did you do any MRI for the brain after just having VP shunt? Is it still the...
I did not.
MRI after VP shunt.
Neurosurgery is following him for that. I did not repeat on my end.
And he didn't have any neurological symptoms, as somebody asked from the audience?
No. Okay. Nothing that the pediatric neurologist could actually point out to. except for the frontal bossing, which, as David alluded to before, probably is from the increased intracranial pressure, nothing else. So interestingly,
yeah, so Raul, before you go on, I mean, the accessory bands that you're talking about have been, I mean, they've been reported for 100 years. In 2007, at Ken Wright's meeting before the Academy of Ophthalmology, I did a talk on ophthalmology from 100 years earlier, 1907. And it was a big year, and lots of famous names in ophthalmology presented stuff. And otherwise, I would not just randomly know this. But the retractor bulbi was reported by I think it was a German, Fleischer, and then but others have reported these bands underneath the muscles, connecting from the medial to the globe, from the lateral to the globe. And so I haven't seen that, mostly because maybe I haven't looked. I don't know. But one of the questions I had for you is, when you decided to do the surgery, if you took the fibrous band off, what did the forceduction show? Yeah. And how did you know what to do once you took the band off, for what the pattern of deviation would then look like? I mean, I might have taken the band off and gotten out, and then woke the kid up and see what they look like when the band was gone, and then made a decision, because I'm not sure I would know exactly what to do.
And that's exactly what happened, David, because I took the band off and I repeated the forceduction. So there was definitely still a little bit of restriction, which I cannot explain. Probably it was from the posterior, a leash effect, if the band was attached. And I'm just assuming this, I don't know, I'm just assuming that it was from that, but definitely it was better. There was still some adduction limitation there. So that didn't go away. So I took that off. And I thought about leaving him there and then, but then, I was like, I need to do something, to definitely, what if it doesn't correct the head positioning at all? So I decided to do this procedure, which thankfully I'd done in multiple patients before on third nerve palsies. So I was pretty sure that, yes, there is this band. And, and while doing my fellowship with Joe Deemer way back at UCLA, we did notice, because Joe definitely does MRIs on a lot of patients, so we did see these accessory bands in as an incidental pickup in some patients, which didn't even have findings which were from the band possibly. So I just thought that maybe, this band definitely is causing something, but I still need to do something more than just excising the band. So I did position the eye with the Merceline suture, non-absorbable, and post-op, it looked pretty good. His head position actually was completely normal in primary gaze. His left eye now was positioned a little bit in the ESO gaze, which is what we wanted, because I'm assuming that it's going to go out a little bit over time. He still has the significant exotropia in the right eye, but since left eye was his fixating eye, he's now fixating really well with the left eye and keeping his head straight. So now the question is, do we go back and do something for his right eye? And if we do that, what do we do?
So he no longer has abduction or adduction?
Yeah, he's completely
fixed in the primary position.
And he's very happy because the head position is gone now. So what to do next? Should we do anything to the right eye, or should we let it stay?
Dear audience, please, I remind you about Mentimeter. The passcode again is 57403225. And we are very happy to have people watching us from Israel, Mongolia, Indonesia, USA, UK, United Arab Emirates, Ukraine, France, Germany.
Actually, we can just inject botulinum toxin.
So where?
In the right lateral rectus, and see how it goes.
That's an excellent thought.
Have you tried that in
not to have any
Duane?
surgery, waiting for the surgery and see the result of the botulinum toxin.
Have you tried it in Duane's?
Yes.
Do you think it works?
This is a bit a difficult case. Maybe Duane, maybe as mentioned, a third nerve or synergistic effect or extraocular muscle fibrosis. But why not? We give it a chance.
So the other interesting thing is his upshoot is still there in down gaze,
Yep.
right? So I don't know, or it's aberrant regeneration, I'm assuming, that's possibly aberrant regeneration from the third nerve. And then he still has the limitation to abduction in the right gaze.
So I mean, we're still, so if he doesn't have abnormal extraocular muscles and he doesn't have fibrosis, then we're sort of giving him a partial sixth and a third or either he has an abnormal innervation of the third from birth, or it's something happened and he developed regeneration later. And we have to talk about what his goal might be for surgery, because the left eye is his fixating eye, right?
Yes.
And he's fixed in midline. He can't look left or right, abduct or adduct. So what are we going to do with the right eye to make him cosmetically look normal? We're not going to give him binocularity realistically, even if we aim for it. So is the goal to fix the right eye so that it's also not moving?
I think that's an excellent question. And that's what I was thinking about at this point. So for me, he and his mom, I've only met the mom so far. The dad has never been to the appointments. They were like extremely happy. They just feel I'm God's son. They're like they're very, very happy at this point. So I think from their standpoint, they don't want to proceed with anything at this point. So I thought about releasing his lateral rectus and doing the same procedure on the other eye. But the other thought is, what am I trying to achieve here? His head positioning is perfectly straight. They are not worried about the cosmetic part. So should we just leave him for now?
This is a bit dodgy, actually. It is a difficult case. What about you, Mina? What do you think?
I would respect the parents. I would not do anything more. The kid is happy, mom is happy. And I would also point out that apart from primary, the looking down position is good for his left eye so he can read. Developmentally, that's very important. So if he can do most of the things in his everyday life with a straight head, I'd be happy.
Actually,
hi, everybody. Sorry.
Hi again.
Hi.
I am so sorry. Thank you. I'm sorry. That's the nature of what we do, right? Emergencies. So I heard this case previously. I just wanted to raise something with the strabismologist expertise. If you have a paralytic strabismus, no matter what the nature of it, what do people think about traction sutures, suturing the eyes after you've done some surgery into either adduction or abduction? In this case, I think the nasal, the periosteal fixation does the same thing, but does anybody use traction sutures at the limbus that they suture to the medial canthus or the lateral canthus, depending on how they're operating in paralytic, long-standing, especially congenital strabismus surgery? Strabismus problem, sorry?
Yes.
Yeah, me too. I have also, Ken. And Alan Scott showed this even in normal monkeys. If you sew the eye into adduction for 2 weeks, take the suture out, they now look esotropic. I mean, the eye will change if you put, I call it a frost suture or a retaining suture. And yes, I have used that in these kinds of circumstances. So yes, it can be done. And I thought, Ken, that I told the whole audience worldwide that you were just big timing us, that you didn't want to show up until the case that you were discussing was here. So no, we told
I have
everybody.
I have to clarify this. It is now 9:46. I've been in the OR since 5:30 this morning with 2 emergencies. So, world audience, please don't listen to my esteemed colleague, Dr. Braddock.
We're just having a little bit of fun. No, we told them that you had the emergencies, Ken. This is real life. You're practicing physician.
Can I just ask again, how do you do it? I put a 4-0 silk suture through the limbus at 12 o'clock and 6 o'clock to 2 separate ones. And then, for example, if I was doing a Mobius syndrome with big ETs, I would release the medial rectus muscles and recess them as much as I could, and then actually put the eye into abduction by suturing to the lateral canthus on bolsters. How do you do it, David? How does Mohammed do it? What do you do when you're using traction sutures to fixate the eye? And I, again, leave them for 2 weeks.
Similarly, but what you described was I would do it 12 and 6. So obviously I'm not putting suture across the cornea. And I do it similarly.
Yeah. Okay.
To hold the eye.
I just do it as Raul mentioned. I do the tunneling myself and do with Merceline and put it at the periosteum nasally for third nerve.
Fantastic.
So, actually, this is really interesting because there's so many things going on in this patient. It's really a fascinating case. I think you have this interesting 6th and 3rd sort of question. The pupils involved. You had a frontal bossing. You had an accessory orbital structure, whether it's the retractor bulbi or it's a fibrotic band that we have to get into. That makes me worry that I'm not doing enough scanning because I don't see this that often. There's just so many things happening at once that I don't think we have a cookbook answer for this.
Great. Thank you so much for the excellent discussion.
Very interesting. Kathy, can you go just and introduce the map?
Actually, there's also one comment from the audience proposing that it could have been drained type 5 as well. And right now, okay, so now we are having the second case presented by Dr. Snehal, and I would like to remind the audience about manti.com questions. Again, the code is 5740-3225. And also, if you need attendance and participation certificates, please send an email to program@wspos.org.
Yes, so hi everyone. At the outset, I'd like to thank Team WSPOS for inviting me over. So are my slides visible?
Yes.
They're fine.
Yes. So I'd like to start with a quote by Benjamin Franklin, which says, "By failing to prepare, you are preparing to fail." So this holds true in case of complex pediatric cataracts. And over the next couple of minutes, I'm going to take you through a case in which, though there was preparation, there were some failures. So let's have a look at this case of a 4-year-old male who was brought by his parents with white reflex in both eyes, noticed for the last 4 months. He came to us in the year 2011, and he was born of a non-consanguineous marriage. He had an older sibling who was normal. So let's have a look at his facial features. He had prominent eyes, a flattened bridge of the nose, as you can see in this picture here, and maxillary hypoplasia and low set ears. On ocular examination, his best corrected visual acuity in the right eye was counting fingers 1 meter and left eye was 2160. His intraocular pressure was normal in both the eyes. His cornea was basically, he had megalocornea. There was no Habs striae present and no posterior embryotoxon. He had cataract in both eyes. Right eye was a total cataract, and gonioscopy was essentially normal. There was no iridotrabecular dysgenesis noted. There was no view to the fundus in both eyes, so we did a B scan, which was essentially normal. So coming on to the biometry, he had a high axial length of 28 millimeters in both eye. And like I mentioned, megalocornea, his right eye horizontal corneal diameter was 14 millimeters and left eye was 13.5 millimeters. So at this point, what came to our mind was we saw the ocular features of having cataract, increased axial length, and megalocornea, along with a few non-ocular features that he had. And what we suspected was stickler syndrome. Obviously, phenotypically, we could not confirm it genetically as yet. So this was our thinking. I'd like to know the panel's opinion regarding this as well.
So, what do you think?
So, well, it's a lovely case. Could you show us a picture of the child's face again?
Yes, yes.
So I think you did all the right things. It was very important to make sure that he didn't have posterior embryotoxon, didn't have any iris hyperplasia, because what you're describing here, flattened bridge of nose, maxillary hyperplasia, prominent looking eyes, you could see in Axenfeld-Rieger syndrome, but you've ruled that out essentially. The other thing I wanted to just say was, when you have horizontal corneal diameters in a child of this age that are more than 13 or 13.5 millimeters, and you don't have Hab-Stree, that can't be glaucoma. So I think you're right. The child has a typical facial features of stickler syndrome. So I would agree with you.
So another thing we could do here, what I thought of was maybe palpate the palate to look for a cleft. What do you think about that?
Yeah, cleft palate is very common in stickler syndrome. Sometimes you get a submucosal cleft. Now, you don't have to do this, but I put a glove on and with my little finger, I feel for the back of the hard palate. And you can see a submucosal cleft. But if you have any suspicion, I always send them to the plastics or the cleft palate team. So yeah, I think you did the right thing again.
Okay.
And I know that they were not genetically there. I was going to ask about the parents. Okay. What you would expect to see.
Yes. So we also examined the parents and the sibling, as I mentioned earlier. They were all normal. And so what we did was a cataract surgery. So what we planned was lens aspiration with a primary posterior capsulorhexis, along with implanting a hydrophobic acrylic single-piece IOL in the right eye, followed by the left eye. But what happened during surgery was there was presence of vitreous. So we also had to do an anterior vitrectomy at this stage.
Snehal, could I stop you there for a minute?
Yes.
I mean, we are ophthalmologists and we're pediatric ophthalmologists, but if you see a child, I think, if you see a child with stickler syndrome, there are a couple of things that you would want to make sure that you referred them to be evaluated. I don't know, do any of my colleagues on the panel, have you seen a lot of stickler syndrome, or are there things that you would do? I don't know. Mina, is there stuff that you would look for other than going, obviously we're going to deal with the eyes, but is there other stuff that you might be interested in?
I want to check his hearing and his heart. I would refer to the pediatrician and ask for a full workup. Definitely.
Musculoskeletal system.
Yeah, they get an arthropathy, and it's worth at an early stage, if you can get foot support, you stop their ankles from flailing outwards, and they get really horrible walking disorders as they get older. So I would definitely make that point for the audience to get that looked at by a pediatrician. Sorry, I didn't mean to interrupt.
Yes, thank you.
Ken, when we're looking at the surgery, is there anything that I don't do a lot of this anymore. I used to, but is there anything that you would do with the anterior capsule and the way you would approach it to get to the lens?
So the thing about stickler syndrome is that the capsule, and Snehal, maybe this is what you found during the surgery, is that the capsule behaves slightly differently. And when you make an incision in the capsule, it tends to get bigger quicker than you would expect in other children of the same age without stickler syndrome. So the first thing is I use the 2-incision push-pull rhexis. So I make my 2 incisions closer to each other and smaller than I would for a regular cataract. And I think when I do the posterior rhexis, I also do a 2-incision, but I guess that's probably what happened, was that the opening got bigger than perhaps the surgeon who was doing it at the time expected, and you got some vitreous loss. I don't know. Is that what happened, Snehal?
Yes, yes.
So it's
it
a
is
great
an
point.
abnormal vitreous. It is an abnormal vitreous in sticklers, as we assume it is.
This is it.
So,
don't you think if we put vision blue, actually this might stiff the anterior capsule tiny bit?
Yeah, you know what? So the fact that, so I would totally agree with you that when I have fellows, when they first start with me, we do use vision blue staining of the capsule, because there have been several really good studies that show that the capsule becomes less elastic. I didn't find it to be helpful in stickler syndrome. I still found that the capsule, not only is it elastic, but it can be a bit like rubber. So it's difficult to manipulate. But yes, I think using vision blue.
Unfortunately, I don't have it. Unfortunately, I don't have experience with it. And do you think if we spare the posterior capsule till later stage by just doing like capsulotomy later on? Because we are afraid in sticklers of the vitreous, and it is a bit the disease.
You know, Mohammed, I don't know the answer to that. I've spoken to a couple of vitreoretinal colleagues this week. One said that it might be a better idea. The other one absolutely said it would not be a good idea, because the YAG capsulotomy with their abnormal vitreous can still predispose them to a retinal detachment. So I have always not done a YAG capsulotomy for that reason in these kids. But obviously the worry is vitreous loss has happened here.
Yes, exactly. So initially we did not plan for the anterior vitrectomy, but we had to do it since there was vitreous loss.
Nihal, what was the IOL power?
So the IOL power in the right eye was +8 diopters and left eye was +8.5 diopters.
And any joint problems?
Yes. So I was just going to come to that actually. We did test the hearing of the patient as well. And we were insisting on a radiographic examination for the joint problems. But due to the socioeconomic status, parents were not very willing regarding that. So we kept insisting on that at every visit.
So, and what about the white measurement?
Yes. So like I mentioned, there was 14 millimeters in the right eye and 13.5 in the left eye. And
did you put a regular lens, the regular posterior?
Yes. That was another point.
And you know that is around 30 millimeter or 12.5 millimeter.
Yes.
Yeah, I mean, I think, Snehal, this is a great case for teaching for everybody, really. If you have a bigger white to white, your capsular bag diameter is normally the same, but your zonules are stretched a little bit. And so if you put in a regular size implant and it's hydrophobic acrylic, there are papers that show that the bag actually shrinks up to 1/3 over 18 months. So that can lead to zonular dehiscence and instability of the lens in the bag.
Yes. So we'll just have a look at the course of events that the child had. So he presented to us in 2011, where he was diagnosed to have cataract, and we proceeded with cataract surgery. Following which, in December 2011, his best corrected visual acuity in both eyes was 20/80 with a near acuity of N12, and IOP was normal. Fundus was unremarkable at this stage. like I mentioned, we did do hearing testing, and it revealed mild middle ear and cochlear dysfunction. And the child also later on had a cochlear implant as well. So this was an additional feature which we noticed. And at this point, I'd like to ask, do you think there is any role of prophylactic barrage laser? Given the fact that his fundus is normal, but he has a high axial length and is predisposed to developing retinal detachment?
Honestly, you could get 6 different vitreoretinal surgeons on a panel like this, and I don't think any of them would be able to agree. So how this all started was in 2008. Martin Sneed's group, who actually found the gene called 2A1 that causes stickler type 1, wrote a paper showing that in a group that got cryotherapy, not laser, that got cryotherapy, the rates of retinal detachment were much lower than if they didn't get cryotherapy. So people started doing cryotherapy and then laser. And then what they found was, and there's a really good review article by Elias Trabulsi in Current Opinions in 2019, where they come to the conclusion that it's not clear, that the actual genotype might help decide whether the prophylactic barrage laser is helpful. And then just recently in clinical ophthalmology, a group, I want to say from Japan, they've shown that if you do laser right at the ora serrata, and it's like really quite heavy laser, that you don't get the problems of the barrage laser that's been done to date. So I think that it's controversial. I don't have enough experience to tell you, but I know that some vitreoretinal surgeons do and others don't. And the reason why they don't is that they say that when you do this, the tear that you get is more posterior and harder to treat if they get a detachment, rather than a big giant retinal tear, which they say can be easier than a posterior tear to treat. That's my experience and my take on it. I'd be interested to see what the others think, what their experience is.
And I found a systematic review in 2020 in Ophthalmic Genetics about potential genotype-phenotype correlations and the role of prophylactic laser or cryo. And what the author said that overall, they found only 3 studies on prophylactic laser. None of them were randomized. And despite the prevalence of retinal detachment being as high as 45% of all stickless patients, mostly type 1, they could not conclude, and we do need more trials because these retrospective trials that have shown a definite prophylactic effect may be biased. So even the experts on this, I think, have not concluded. So we need more data.
I think
that's such a good point.
Yeah.
Sorry, Ken.
It's still a controversial issue, actually.
Yeah, and I think, for us, it just seems to be that the few people that have gone for prophylactic laser, it's because the parent who has sticklers had a retinal detachment and they fear it. And so they're happy to go prophylactic. But if the parent did not have a retinal detachment, it seems that then we don't do the barrier as quickly, which is immediately a bias, right? So try to understand the genetic differences and understanding who's going to be benefited by this. I think that still needs to be answered.
There's also the question of age. At what age do you do the prophylaxis? Maybe you're already over the risk of having a retinal detachment. And that's a point raised in the review. Mostly, it seems that a retinal detachment comes in the 2nd decade of life. So if you see a patient who's older, maybe they have overrun the risk. But again, there's a lot of variability.
I think if a child
so maybe close follow-up by a retina surgeon is mandatory.
Yeah. I think if a child under the age of 10 has had a detachment, however, then most of them tend to get prophylactic laser in the other eye. That's been my experience with my colleagues here at Pittsburgh.
Right. So thanks for all the valuable comments. So we'll move on to 2012. The child was doing well, and his visual acuity improved to 20/60 N6, and his fundus was normal, and the intraocular pressure was normal as well. In 2013 and 15, he was stable. His visual acuity had improved dramatically, getting a visual acuity of 20/30 in a case of sticklers, which is really good. A near visual acuity of N6. His fundus was normal, and the intraocular pressure was normal as well. So we also insisted on genetic testing and imaging, like I mentioned, to rule out musculoskeletal defects. But given the socioeconomic status, the parents were not billing for the same. So I'd like to ask the panel, how many of you all actually do genetic testing in such cases? Does it alter your management in any way?
So I think, Snehal, that's a great question. I think that there have been a couple of studies, as we talked about, genotype phenotype correlation for prophylactic laser. One of the things that I do is I think that clinically you can really try and make the diagnosis. So what I mean by that is this: when you do the slit lamp test in these patients with sticklers, what you're looking for is the optically empty vitreous. And there are the two types that we see, type 1 and type 2. In type 2, when you see the membrane, so I always tell my fellows and my residents that the way to imagine it is if you're driving at night with your light beams on and it's a foggy night, you can see the light beam going all the way across. Now, if you do that with a slit lamp with a 3 millimeter height, 1 millimeter width, and you shine it into the vitreous, if you can see the beam of light behind the lens, even if you can see something moving in that beam of light, it's not optically empty. But if when you see the beam of light after the lens, it goes black with no beam of light seen, and then suddenly you see it landing on the membrane, that's an optically empty vitreous. Now that membrane can be thin or it can be thick, but if you see little beads on that membrane, that's type 2 stickler. So you can clinically differentiate, and it's, I would say, about 80 to 85% accurate going from the clinical to the genotype, trying to make the difference between type 1 and type 2. If you don't see any beads, that's type 1. If they have a cleft palate and optically empty vitreous, that's type 1. Type 2, you tend not to get cleft palate, but they both get arthropathy and they can both get hearing problems.
Yes, these were very nice, important pearls. I think it's going to benefit a lot of people who are listening to us at this moment. Thank you, Dr. Ken. So we'll move on to 2017. So from 2015 to 17, the child was stable, and he presented to us in 2017. He was 10 years of age at that time. He came with blurring of vision in his left eye. His visual acuity had dropped to 20/40. With a +5 sphere, and he was aphakic. On fundus examination, what we noticed was the IOL had dislocated posteriorly, and we also noticed that there was a retinal hole inferiorly. So now, yes.
We're coming to just putting an IOL in such a patient and not putting an IOL in such a patient. So if we leave them without IOL, so maybe the refraction will be out of +4 in each eye and awaiting for the others. So because he's high myope. So yes. This is it. So the IOL, as I mentioned, with the white-to-white measurements and others. So we are in a dilemma now. So the IOL is in the posterior pole. What do you think, Ken?
No, I think this is a great case. You know, I have always tried to share the cases when you share surgical cases that haven't gone exactly as you would wanted them to.
Absolutely.
Because this is the way people learn. So Snehal, firstly, thank you for sharing this. It's interesting, there's a YouTube question. Somebody said, is it not detrimental to put an implant in a bag with where there might be progressive zonulopathy? And this is what we talked about earlier. So this is a great lesson. You know, if you have somebody who has a high axial length and you're putting in a low power IOL, think twice about whether you need to put that IOL in case you get this kind of situation. What do my colleagues think on the panel? Any experience?
I had a patient before. He's not a stickler, but he has a large globe, so 26. But the white to white was 12 and a half. And I did an IOL for him myself. And just because of minor trauma, he had the intraocular lens in the posterior chamber. So these people with large globes, so they might just get this.
Yes, so now we had a dislocated IOL in the left eye. And obviously, we have to remove that IOL. So along with that, I'd like to know your opinion. What should be the plan of management? Should we leave him a phakic next? Or should we do a secondary IOL, be it a iris clip lens or a scleral fixated or a glued IOL? So the panel, maybe y'all can help with this.
Okay, so
iris clip is an option.
I'm going to start, and I want to say this. I think the thing I love about WSPOS is that I have learned that people have to change their approach to the patient depending on where they live in the world. It's very easy for me to say, I would leave the child aphakic, I'd put him into a contact lens, I'll get glasses for him, because in the United States, I can do that very easily. But there are parts of the world, and I'm sure in India, where you're worried that if you don't put something in this eye, this child's parents are not going to afford glasses, they're not going to afford contact lenses, and given his age, he may end up with amblyopic visual loss rather than the risk of a secondary IOL. And I think this is the most crucial thing that we can do when we exchange ideas, is for us to understand and consider what our colleagues are dealing with in different parts of the world. So what I would do is leave him aphakic in the United States. But if I had to put a lens in because I was worried that he wouldn't get any visual rehabilitation, then I would put in an iris clip lens rather than a scleral fixated lens, because he's got abnormal collagen and he's growing. So those would be my options.
And for those of us who grew up in the USA and don't have the value of the experience that you have with the iris clip, can you take a second and talk about the iris clip lens, or anything we might have to worry about in sticklers that's associated with it? Because we're way behind here, a good part of the world.
Yeah, so again, when I moved here in 2011, I was horrified that there were no iris clip lenses, and we had to go through an FDA-approved study. So the iris clip lens, many people around the world have used. It has haptics that enclave the iris. There are parts of the world where they do retrofixation, so you turn it upside down and fixate through the pupil so that you can't see it. But in the United States, the FDA-approved study mandates that you have to put it in the anterior chamber. The problem is trauma again. If you get trauma, it can dislocate. And now, if it's on the front, it dislocates and can cause a problem to the endothelium. And if it's in the back, it's going to dislocate into the back of the eye. But in my experience, it has to be a hefty blow to the eye to cause a dislocation in a child. So that's really, and there's some great YouTube videos if you want to watch them about how to do it, and it's reasonably straightforward.
Is there anything about the iris and sticklers that would make you pause for a moment before doing an iris clip?
So the COL2, so in type 1, collagen type 2A1, there isn't much of it in the iris. And again, COL11A1 is the same. So you can get iris transillumination in stickler, but it's mainly because the eye is so big. And I would look for iris transillumination in this child. If he didn't have it, and I had to put in an implant, then I would use the iris clip.
Actually, as you mentioned, because it is a collagen disease, so you don't just put it scleral fixated. And also scleral fixated, how long it will last. So if you put even 9O nylon, as mentioned by I forgot his name. So if you put 9O nylon for suture, so this will last for up to 9-10 years. So
yes,
and the patient will.
Yeah, Mohammed is 9O proline. It was Ed Buckley who
Ed Buckley, yes, Ed Buckley. Yeah. Thank you very much.
Yeah, I think that there are some better techniques where they use no sutures and they actually fixate them through the sclera and glue them in, which probably, Snehal, you're going to show us. We'll stop interrupting because we keep interrupting you.
This was mentioned also by Vazavada. He has a series of more than 50 cases in pediatric patients with no suture in the posterior pole.
Okay. So what we did for this patient was vitrectomy with an IOL explantation, endolaser to the retinal hole, which was present inferiorly, and a glued IOL. So what happened was from 2017 to 2021, he was stable. And then he came back to us for the last follow-up in 2021, where he was 14 years of age. His best corrected visual acuity was 20/30 in both the eyes. The intraocular pressure was normal. So as you can see in the left eye, he has a very high cylinder of -4. And as you can see in this picture here, what is happening is the arrow above, where you can see the distance between the cornea and the IOL, and compare it with the one below cornea and the IOL. The one below is bigger, meaning the IOL is tilted. So this is what happened in 2021. The left eye IOL had tilted, and even the right eye, you can see that the margin of the IOL is in the pupillary plane. So this is what was happening here in 2021. And this is also seen very nicely in the picture here, where you can see beautifully in this picture that the IOL has tilted very much in the left eye and in the right eye as well. And his fundus was examined, was normal. You can see here that the hole is very well enclosed by the laser marks here. So this is what I would want the panel to tell me about. What do you think should be done next, in the sense that what would be the ideal time to intervene in the right eye? Because you can already see that the IOL is tilted. And in case it dislocates, what should be the next step? Should we leave him a phakic, or should we do a glued IOL like we did in the left eye?
Again, this is such a great case, such a great learning tool. Could you tell me what is the refraction in the left eye? It's plus, the left eye is +2 with a,
yes,
with a -4 sil?
Yes.
So he's got a spherical equivalent of 0, basically, hasn't he?
Yes.
So if you left him a phakic in the right eye, what do you think he'd be, about a +4, +5?
Yeah.
Yeah. I mean, so these would be my worries. My worry for the right eye is that if you don't do anything prophylactically, that lens is going to dislocate, and he may develop a bigger retinal problem than a small hole that he got in the left eye. So that's one concern. The other concern is there's a lot of sil in that left eye, which suggests to me that the lens is tilted.
Yes.
So I would actually suggest that there's another option, which is remove both lenses and leave him aphakic.
Okay.
I mean, I think that's got to be an option on the table. If you wanted to do a glue fixation, because that's what you've done in the left eye, then you'd have to just accept the possibility of the complications of, an abnormal sclera and a growing eye.
Right.
I personally wouldn't do that.
Nehal, can you tell us how often can you examine the patient? I mean, realistically, what can his parents comply with a close follow-up?
Yes.
Because let's not forget, this vision is far too good for me to intervene right now.
Right. So his parents actually... Yes. So his parents actually, they stay very far, so they can come every 6 monthly to us. It cannot be a closer follow-up than that.
What's his vision in both eyes now? Sorry, I missed that.
Yes, he's 20/30 in both eyes.
Oh, that's that's really good. And he's 14, right?
He's 14, yes.
Yeah, so that's, you know, it's a difficult case. He's got good vision. I mean, there's an argument to watch as well, because if you go in to remove the lenses, you could cause a retinal problem too. I think for me, it would matter about the discussion with the parents. You know, what would they think? And if the worst question I always get asked is, if this was your child, what would you do?
Yeah.
And I can't answer that question, because if it was my child, I wouldn't be operating on him or her. So I think you have the options, as you've discussed. Take out the right lens, glue another one in the right, or take out both lenses and leave him aphakic, or just take out the right one, leave him aphakic, and see how he does.
Yes, I feel removing both lenses and leaving the child aphakic seems like a very good option, actually. I mean, not maybe at this stage, we can keep him in a follow-up because his visual acuity is really good.
I know that not everybody on the panel deals with these cases, but you probably see stickler syndrome cases. So what are the panel's thoughts? You know, Rahul and Mohammed, Katya, Meena, David, what are your thoughts? What is your gut instinct?
I should also tell about the opinion of our audience. Actually, they switched almost by half. 44% are for aphakia with glycis, and 44 are for iris clip IOL. Only 11 are for scleral fixated IOL.
Yeah, this is a great case. I mean, it's a really good case.
Actually, if you want to ask me, I leave him myself aphakic without any lens implantation.
Yeah, and I think the one thing that I've learned over the years is that it's very easy for me to say this is what I would do, and not in the shoes of people who are amazing surgeons and have a different environment where the patient lives and where they live and work, and they have to take that into consideration. I think that's the most important thing, is for whichever study you read, is to apply that study to the environment and the equipment and the needs of your population.
You know, I don't have a wealth of experience like Ken does on these cases, but most definitely I will have a very good discussion with the family about this, you know, and kind of take them into consideration, you know, their thoughts as well. Because honestly, I would want to make him aphakic, but easy for me to say that his vision's 20/30 in this eye. So it's very hard to take that decision. So I think the family should be involved in this, making the decision at this point as well.
If I may make a final point, I think regardless of the IOL or no IOL, I think it's very important to underline that for his vision, for this child's vision, it's very important to make sure the parents comply with surveillance, because it's likely he may get retinal problems with or without an intervention from Usenel. I think we shouldn't forget this, because it's for all stickless patients, and we make sure we remember to make them comply with it.
Thank you very much.
Excellent. Well done. Thank you very much. I think we're coming to the end. Kathy, would you like to just end the session yourself, or if any from the panel has any comment, just one comment each before just finishing the session?
I have a couple of things that I want to say. I think the value of learning from cases like this is enormous. because we're not all going to be able to see unusual cases and know exactly what to do. And to be able to share this, I think, is phenomenal. I apologize that I couldn't be on at the beginning of the webinar. If I could ask a question of the panel, when you see a rare disease, and we've seen 2 rare disease cases today, what is your pattern of thought regarding the overall care? Do you find that the general pediatrician or colleagues of yours who are not ophthalmologists, that you sometimes have to help them, direct them to, this is a rare disease, we need to work together to figure out what's the best for the child? I'm just interested in how you deal with the rare disease child that turns up to your clinic.
Sure, it will be a multidisciplinary issue, and we just refer them to the pediatrician or a subspecialist in pediatrics just to help us in the diagnosis and the management also.
Yeah, Ken, this came up a little bit in the first case when Raul basically sent the child for scanning, right? I mean, the ophthalmologist was able to identify a neurosurgical problem. And the second case, you have a child with a systemic disorder. In both cases, the eye was the red flag for other issues. And if we don't pay attention to that, we're not doing our job as pediatric ophthalmologists. It's so easy to put blinders on, if you will, no pun intended, of saying we're just eye doctors. But that's not why we go to medical school, and that's not why we learn all of medicine. And I do find that because ophthalmology is siloed, especially pediatric ophthalmology, that if we're not careful to interact, that there's something lost for the care of the patient, that we need to be able to interact with the rest of the team and help point the team, saying to the radiologist, what are we looking for when we order a scan? And then looking at the orbit, Raul, nobody saw the accessory band, and nobody will ever see that except an ophthalmologist. So we always go over the scans ourselves in addition to the radiologist. I think that without that, we're not giving the quality of care and the kind of care that children deserve and adults deserve too when it comes up. So we are doctors. And if we don't interact with the team and pass on what we know, they don't know ophthalmology. I mean, honestly, people don't know ophthalmology if they don't do ophthalmology. So it's up to us to know what they do more than they know what we do.
I would like to completely echo what David said. And I feel very fortunate that I'm working in a children's hospital sector where we can easily interact with our colleagues. And we have a very collegial relationship with all the subspecialty faculty. And we definitely engage in a lot of multidisciplinary sessions. And we have a ping system where anytime we find anything unusual in our clinic, we can easily ping our colleagues and immediately we get the answer and they get the patient in right away. So I think these are excellent points which Ken and David, you've raised, that the more of this, if it happens in the world, the better care we can provide to our patients.
How many people, I know we're running out of time, but how many people on the panel work in a children's hospital? How many work in an eye hospital? And does that influence how easily you can communicate with your non-ocular specialists? So I'm in a children's hospital.
Children's hospital.
Children's hospital.
Both.
You're in both?
Eye hospital and both.
General hospital.
I work in both.
So, but you're not in a standalone eye institute, Mina?
No, it's a general hospital. So I have, in the same building, there are radiologists and pediatricians who I love to work with. And this is what makes it so fun. I learn so much from them. I feel I wouldn't be able to deal with any difficult case on my own. I love working with others, and I think it fills up any insecurities because they have questions on issues that I'm more familiar with, as David said, and the other way around. So talking to the microbiologist about a case, or to the pediatrician or the neurosurgeon, is what I enjoy most. And it makes life a little bit easier.
David, Snell, you're both in eye institutes, right?
Yeah, so I'm in an eye institute that is part of a large medical center, and the Children's Hospital is a separate site. What I find is that interacting with the Children's Hospital is fabulous, but also, since we're a vertical specialty as well as a horizontal specialty, having all of the subspecialties within ophthalmology and all the equipment that goes along with that available has been a great advantage, as well as dedicated ophthalmic ORs. So I think there's advantages to being having access to both. So as we wrap up, I know that we had a little trouble with some of the slides. Let's see if I can get some of these slides up. I did want to show one thing really quick, because I Googled it while we were all talking, and I found this article by Greg Leader from 2002, Raul, on the anomalous orbital structures that I had referenced. It's a great article with lots of pictures that look just like your patient if you go through these, the images. So I want to give Greg a shout out. And he's got some of the bands that you can see, including what he found in the OR and some of the MRIs. So that was the one article that I remember clearly about that that I had seen. And then for our participants, as was noted earlier, send an email to program@WSPOS, and program is spelled not the American way. For those of you who want to know. And then we have all the slides. That's my family. Everybody pictures of theirs. Ramesh, prayers are with you, and we love you and miss you.
Get well soon.
Get well soon. Yep. And then Mina included her pictures. I love the dog, so I want to meet the dog one day. And then Ken, whose family is much better looking than he is. And thank you for sharing. Ken, can you explain the picture for all those of us who are ignorant with everybody with all the wonderful colors all over them?
Oh, that's a wonderful Hindu festival called Holi. And you chuck colors at each other, and it's a celebration of life and renewal. I'm sure there's everybody in India saying he doesn't have a clue what he's talking about, but that's my Hinduism for me.
Thank you. Mohammed, is that going to the golf course that you're going golfing there in the upper picture?
This is Bobli Garden in Rome. Bobli Garden.
Ah, got it. What a beautiful family. And Katerina, is that the Alps, or where are you skiing?
It's in Ukraine.
Oh,
welcome.
In Ukraine. Oh,
yes, welcome.
How
skiing.
Beautiful.
Fantastic.
Yes, we need a ski meeting in Ukraine so we can all see, because that's beautiful view. And what a lovely family. Thank you for sharing. Snehal, thank you for sharing your case. And tell us where those beautiful background pictures are.
Yeah, so that's Seychelles, actually.
Nice.
We just went there before COVID came in, so yeah.
Raul, I know California is a beautiful state. We don't want too many people moving here, so don't say any wonderful things there. But this is beautiful, and what a wonderful, beautiful family. So thank you to our audience. Thank you to all of our speakers and moderators. You all were wonderful. And Todd, our fabulous host for all of these webinars. Once again, you are spectacular. To our admin team, Dara, and the wonderful Akila, thank you so much for all your efforts. For those of you out there, what you don't know is without the two of them, none of this actually occurs. Doctors turn out to be actually not so easy to work with and get to do things. So thank you so much for your patience. Here are upcoming webinars that you can see. We continue to provide free education for those of you around the world. Membership in WSPOS is free. We'll have more webinars coming up in July on nystagmus and electrophysiology and ocular pathology. And please don't forget, membership is free in WSPOS. We believe expertise resides all over the world, and it should be accessible. Join the Facebook page and group. There are thousands of your colleagues on both of those. Subscribe to the YouTube channel and join the 3,000 other people who have subscribed. All of our webinars to date are available there and accessible. So it's great content. For those of you who want to join the international listserv that we started over 25 years ago, you can email me at dgranite@ucsd.edu. Let me know who you are if we have not met before, so we can add you to the listserv and join the ongoing conversation. So let me stop sharing and give this back to our moderators to tie up our discussion.
Thank you, David. Thank you very much. Thank you, everybody. It was excellent. And sorry for the technical problem that happened in the first webinar. And we'll see you soon. Actually, we'll see you in May, 8th of May, with inherited retinal diseases. Thank you for the presenters, the discussants, and also for the moderators. Thank you very much. We'll see you soon. Thanks a lot.
Thank you very much.
Bye. Thank you.
Thank you. Bye.
Mm-hmm.